All right, welcome to this webinar on Introduction to Viral Hepatitis Testing and Treatment. My name is Danjuma Ada. I'm president of the World Hepatitis Alliance. The World Hepatitis Alliance is the large international network of organizations that drives advocacy, awareness creation, and demand also from the community to improve access to care. We are in over 100 countries, and we have over 300 members across the globe. And this project is a collaboration, and we're happy to see that the World Hepatitis Alliance is the one hosting this, and we have a very great speaker who is a public health person and a hepatologist, whom I'll call on Jess actually to do the honor of introducing her. But for all those joining also maybe from outside Nigeria, we hope you get to learn about the best practices on viral hepatitis testing and treatment. Now, to set the ball rolling, we need to understand that in 2016, the World Health Organization set an ambitious goal of eliminating hepatitis by 2030. Unfortunately, as of 2019, more people have not been diagnosed with hepatitis. As a matter of fact, globally, only 10% of the 296 million people living with hepatitis B were diagnosed, and 2% placed on treatment. In Africa, only 2% of people have been diagnosed that are living with chronic hepatitis B, and only 0.1% of this number have been placed on treatment. So to meet the ambitious goal of hepatitis screening, which the World Health Organization have set for 90% of people who are unaware of their status to be diagnosed, there's need for improve and scale up of testing and linkage to care. And sadly, as we know, hepatitis, we call it a silent killer because about 9 out of 10 people living with viral hepatitis are unaware of their status. And therefore, there's a very great need for massive increase in testing so that countries will be able to meet up with the WHO target of screening 90% of these populations that need to be diagnosed. So I welcome you to this webinar, and I hope you sit back with your writing materials or to listen and learn from this eminent speaker that we have on the call. But I'll hand over to Jess, who is the director at the World Hepatitis Alliance, to give you a little background to this webinar and this project that we are hosting. Thank you so much. And please, we are going to open up to question and answers after the presentation by our speaker. But thank you for joining us, and over from me.
Thank you so much, Danjuma. We're just so pleased to be here today and to be joined by Dr. Ruth Adabe Bello. The reason sort of behind this webinar, as Danjuma mentioned, the Alliance has been working in Nigeria for quite some time now. So our first in-country project ever really was in Nigeria in 2017 when we worked with CHI on the investment case for hepatitis C elimination. And since then, we've constantly been looking at ways that we continue to drive that forward. And so this year, we were really pleased to be able to partner with 2 members in the country to look at advocating for financing. But beyond that, we wanted to work with you all and provide a source of training materials that would be beneficial to you and your networks. And so the feedback from our incredible advisory board made up of WHA members in Nigeria was that this was a really important topic. And I think Danjuma just set the scene as to why it's so critical. And, we aren't going to reach elimination. We aren't going to access the financing we need without improving the knowledge of and access to testing and treatment. And so with that, I'm going to hand over to Dr. Bello to take us through the introduction to hepatitis testing and treatment in Nigeria. Oh. Dr. Bello, you're on mute.
Good evening, everyone. I want to welcome you to this webinar. Today, I'm going to walk you through viral hepatitis testing and treatment. Next slide. Okay. We are going to go through this outline introduction to viral hepatitis. We want to look at the comparisons of the hepatotrophic viruses, epidemiology, testing, treatment, global health sector strategy, and Nigerian Nigerian strategy for combating hepatitis infection. Hepatitis, as we all know, is the inflammation of the liver. It could be acute or chronic. When we say it's acute, it's lasting less than 6 months, while chronic is lasting greater than 6 months. And there are various agents that can cause hepatitis. We have viruses, we have bacteria, toxins, chemicals, autoimmune. When we mean autoimmune, that's your body makes antibody against the liver, against the virus. And also what we are going to concentrate today is the viral causes of hepatitis. We have hepatitis A, B, C, and D. So when we want to look at the hepatotrophic viruses, because those are the area that we want to concentrate more for this webinar, where viral hepatitis is a group of viral infection affecting the liver, predominantly caused by viruses based on etiology, that is hepatitis A, B, C, and D. Although the agents, usually the symptoms is the same, it is difficult to differentiate them based on the symptoms. However, they differ in their antigenic property. Where hepatitis A and E, this cause acute viral infection. It doesn't have they don't have chronicity. But hepatitis B, C, and D, these are the viruses that can cause chronic hepatitis, and also they can cause damage to the liver, cirrhosis, leading to cancer of the liver. So when we are comparing the viruses, we have A, B, C, D. If you look at this table, all the viruses are RNA viruses except hepatitis B, which is a DNA virus. And also their mode of transmission. If you look at those that cause chronic hepatitis, that's B, C, and D, their mode of transmission is similar. While hepatitis A and E, their mode of transmission is fecal oral. If we look at the incubation period of these viruses, hepatitis A and E, they cause acute hepatitis. They have shorter incubation period. When if you look at B, C, and D, they have a longer incubation period. So epidemiology, when we look at globally, if we look at the burden of hepatitis C, as Dr. Danjuma has said earlier, hepatitis C affects about 58 million persons are living with this virus in 2019, and it accounts for 3,000 deaths in 2019. Well, for people that know their status in 2019 were about 15 million people, and out of these 15 million, only 9.5 million were treated for hepatitis C in 2019. When we look at the global burden of chronic hepatitis B, about 296 million people are living with chronic hepatitis B. And out of this, it accounts for 800,000 deaths in 2019. And if we look at the immunization coverage, only about 85% of coverage of hepatitis B vaccine that were able to receive up to the 3rd dose. And about 30 million people know their status. Only 6.6 million received treatment in 2019. Well, for us here in Nigeria, we know Nigeria is a high burden country because the prevalence is in Nigeria, following the NICE study in 2018, the prevalence of hepatitis B in Nigeria is 8.1%. That's about 16 million people are living with this virus in Nigeria. When we look at the prevalence of hepatitis C is 1.1% following the NICE study, which account for 2.2 million people are living with this virus in Nigeria. Well, this is the global prevalence. If you look at this map of the world, if you can see the area that has high prevalence is painted dark. Any area with more than 8%, it means it's high prevalence, in which us here in Nigeria were among the country with high prevalence of hepatitis B. Sorry, my cursor is not moving.
Would you like us to move to the next slide?
Yes, I want to slide to the next slide, but it's not moving. Okay. So the burden in Nigeria, there was a study that was done in Federal Ministry of Health in 2013. If you look at the prevalence in the country, the states with high prevalence, they are the northern states, Kano, Gombe, Kwara, they have high prevalence. So also this slide is showing the prevalence of hepatitis B surface antigen among the population in Nigeria. The study was done in different states, and states that have high burden are most are the northern states. Okay, so still the Federal Ministry of Health tried to look at the risk factors that predispose individual to chronic hepatitis B virus. And from this diagram, you can agree with me that if you look at this, that's local circumcision among people that were hepatitis B positive, or about 43% of them had history of local circumcision, which is a common practice that is being done in the northern states. That will account for the high prevalence in the northern states. There are other risk factors. Scarification and tattoo are also among the high reason, the risk for the viral infection. Okay. So likewise for hepatitis C, local circumcision is still one of the risks driving the infection. You can see that it's 52.4%. And scarification, tattoo, body piercing, they are also, those are the risk factors that were found based on the study that was done in with Federal Ministry of Health. Okay. So now I would like us to look at the viruses individually. So for hepatitis A virus, which is from the Picornaviridae family, and I've said earlier, it only causes acute infection. There is no chronicity with this virus. Mostly it causes mild infection, and the person that is infected recover completely and develop immunity against this virus for further infection. And here in our country, because it's a low-income country, a lot of people by the age of 10, they have developed antibodies against this virus. So, and immunity is one of the way, immunization is one of the way of preventing hepatitis A virus, in which there is immunization for it. For hepatitis D virus, which is a Delta virus, it's an incomplete virus. And we know that this virus cannot exist alone without hepatitis B infection. So if there is no B, there won't be hepatitis D, because it can either occur as a co-infection with hepatitis B virus, which can cause severe liver disease, also leading to acute liver failure, or it can occur as a superimposed infection with hepatitis B. That is, someone is hepatitis B positive before he becomes infected with hepatitis D. And in this case, usually the risk of progression to cirrhosis and liver cancer is fast. Hepatitis D affects about 5% of people infected with hepatitis B. And a recent estimate from 2020 suggests that currently about 48 million persons are infected with chronic hepatitis D virus. So hepatitis E, I told you it causes acute hepatitis, and usually is self-limiting. However, it can cause fulminant hepatic failure, that's acute liver failure. It doesn't have chronicity. If a woman is infected at third trimester, it has 20% mortality. on pregnant women and also newborn babies. So let's look at hepatitis B virus, in which the center of our discussion today is going to be based on hepatitis B and C, because those are the viruses that causes chronicity. Hepatitis B virus was discovered first in an Australian aborigine in 1960. It led to the identification of hepatitis B by Baruch Bloomberg, that's in 1967, and he developed a blood test to detect this virus. He also produced the first hepatitis B vaccine in 1969, and he got a Nobel Award in 1976. It's from the Hypnaviridae family that primarily infects the liver. It's 100 times more infectious than HIV virus, and is 10 times more infectious than hepatitis C virus. Because hepatitis B virus, HIV cannot live outside the body, while hepatitis B and C can live outside the body. That's why it's more infectious. Hepatitis B is a non-carcinogen, and 25% of chronic hepatitis B infection progress to liver cancer. I've already said that the prevalence is about 8.1. Male to female ratio is more in male than female. If you look at it, it's almost like double. This is because the female in their younger age, they have estrogen. So that gives us some protection against this virus. That's why it's commoner seen in male than women. And infection occurs most commonly between the age of 21 and 40 years. Substantial perinatal and childhood transmission occur. Healthcare providers are at great risk of infection. So if we look at this diagram, it tries to tell us all about the endemic countries, how they get infected. Because if we look at in the endemic country, the mode of transmission is either vertical, that is from mother to child, or early childhood. That's the commoner way of getting infected with hepatitis B virus. And once, if a child becomes infected during vertical transmission, that's from mother to child, the chances of progression to chronic hepatitis B infection is about 90%. But if someone gets infected during early childhood, that's between age 1 to 5, the chances of progression is about 30%. Well, if you become infected as an adult, the chances of progression is about 1 to 5%. And symptom-wise, because when you are a child, you don't have immunity. You don't have immunity. You cannot. Your immune system is not well built. So when this virus enters the body, it just stays there and begins to multiply. That's why the child is not symptomatic, and the virus continues to multiply, and the body is not able to clear the virus. That's why once if a child becomes infected, chances of going to chronicity is about 90%. So this is the structure of the virus. It has an inner core protein and an outer core protein, which the outer core harbors the surface antigen, while the inner core has the DNA. When we look at the life cycle of this virus, I'm just going to talk briefly about the life cycle. Once if it enters the body, if you look at this diagram, this is the nucleus of the host. So this virus enters the nucleus and forms the covalently closed circular DNA. Then transcription, a lot of things happen there. Then it throws back into the circulation, and the cycle continues. B has no cure. There is no drug that is able to penetrate this nucleus. And once the hepatitis B enters the nucleus, it gets integrated into the host genome. Then it begins to be most difficult to cure hepatitis B, unlike hepatitis C that does not enter the nucleus. We have hepatitis B has about 10 genotype A to J. However, this genotype, we don't talk much about hepatitis B genotype because the treatment for hepatitis B, the drugs treat all the genotype. However, what I want us to know is that the commonest genotype that we have in Nigeria is genotype E, while genotype C is associated with severe liver disease and can progress faster to hepatocellular carcinoma, while hepatitis A and B has milder disease. So let's look at the goal of treatment for hepatitis B virus. Usually, the goal of treatment, the ultimate goal is to have surface antigen loss. That's someone that is hepatitis B surface antigen positive to become hepatitis B surface antigen negative. That's the ultimate goal, which is difficult because of the covalently closed circular DNA that is formed in the nucleus, and there is no drug that has been able to penetrate the nucleus. That is why it's difficult to achieve this. However, other goal of treatment is to decrease the hepatitis B viral load to undetectable level. That's the level that is detectable to undetectable. That's one of the goals that we want to achieve when someone is being treated for hepatitis B. And for those that are E antigen positive, we want them to have the E antigen should be negative. Then biological response, we are looking at the ALT from abnormal ALT to normal ALT, and that's what we aim to achieve when the person is being treated. And also for those that were able to do histology, we want those that are from inflammation to decrease inflammation or minimal inflammation or no inflammation at all. Also, we want the patient not to develop cirrhosis or cancer of the liver. That's the reason for treating, the goal for treatment. So who will you want to treat in patient with hepatitis? Any person that has hepatitis and has cirrhosis of the liver, whether compensated or decompensated, is an indication for treatment of hepatitis B. And also, if a person have DNA of greater than 20,000 international units, that's viral load, and also has abnormal liver function test, is an indication for treatment of hepatitis B virus. Also, those that have low viral load, however, their liver ALT, alanine transaminase, is abnormal, those persons should also be treated. Well, Society for Gastroenterology and Hepatology in Nigeria said that if you have abnormal liver function, abnormal alanine transaminase alone in a patient that is hepatitis B surface antigen positive, is also an indication for treatment. And also, if you have a family history of cancer of the liver, if you have lost somebody from cancer of the liver and you are hepatitis B surface antigen positive, it means you need to be treated irrespective of the alanine transaminase, irrespective of your viral, whether the viral load is undetectable, it means you need to be treated. Once you have lost a relative that has cancer of the liver, it's an indication for treatment. Basically, it's not everybody that has hepatitis that needs to be treated. So there are some parameters. If someone is young, that's less than 20, he has hepatitis, and his viral, even if the viral load is high, but it's not, the liver function test, the ALT is normal, and he has no family history of cancer, he does not need to be treated. We can monitor the patient. And also, antiviral is not recommended at all if the patient does not have cirrhosis and the viral load is low and ALT is normal, he does not need treatment. However, even at that time, if someone does not need treatment, someone needs to be monitored regularly, because those that do not need treatment at that time may need treatment later. So if you don't need treatment now, you need to be monitored regularly, because you may need treatment later in the course of the monitoring. Okay, so what is the rationale for monitoring patients with hepatitis B surface antigen positive? Approximately about 20 to 30% of inactive chronic hepatitis B virus may spontaneously develop reactivation of the hepatitis of the virus during follow-up. So that's why the patient needs to be treated, to be monitored closely. Once, if you don't require treatment, you need at least to see your doctor at least twice in a year for monitoring. And in this monitoring, what do we look at? We look at the liver function test, that's alanine transaminase. We do alpha-fetoprotein, which is a tumor marker, and we do an abdominal ultrasound. Then annually, we monitor the patient by doing viral loads once a year, so that if someone's viral load is undetectable, if it becomes detectable later, it means the person needs treatment, so that you need to treat, because from inactive, one can become an active carrier. However, there are risk factors. Risk of hepatocellular carcinoma is not completely eliminated in an inactive carrier patient. So usually there are things that can make somebody that is inactive to become active. As you get older, your immunity is low, you may likely seroconvert, and also male history of cancer, alcohol consumption, obesity, and diabetes. They are all risk factors for progression. Before someone gets treatment for hepatitis, the patient needs to be counseled appropriately. And also they need to avoid further health risks such as alcohol, herbal concoction, aflatoxin, which is found in the Moody granule, because multiple sexual partner, tattoos, all these, they are risk factors for becoming infected, for getting infected with other viruses too. And also alcohol, herbal concoction, they can destroy the liver. So there is need for the person that is hepatitis B surface antigen to positive to avoid those risk factors. Also, the person needs to know the health implication of chronic hepatitis, because it can cause liver failure, cancer of the liver, cirrhosis. Also, the chronic nature of the disease. That's why monitoring and treatment may be lifelong, because if someone is hepatitis B positive and he's commenced on treatment, the chances that he will do the treatment for life is high, because treatment is actually lifelong. The possibility that spouse, children, and close relatives may be infected, and they need to screen and protect if uninfected. So that if once someone is hepatitis B positive, you need to screen the other family members to be sure they are negative, so that those that are negative, they can be vaccinated. So what are the drugs for treatment of hepatitis B virus? If we look at this diagram, it shows us from 1998, we started with the interferon through 2018, when tenofovir alafenamide was launched in the market. So these are the drugs that we use for treatment of hepatitis, but the commonest one that we use is tenofovir, because it has less side effects and also less side effects on the kidneys. There are some that don't respond to treatment. What will account for that? If you are on treatment for hepatitis B and you do your viral load, you discover that the viral load is not going down, or the viral load was undetectable, it became detectable. So there may be things maybe going wrong. It's either the drug is not working, or you have developed resistance, or you are not compliant to the medication. So first of all, we check for compliance to be sure that whether the person is actually taking the drug as prescribed, and is he taking the drugs with other medication, because there are some drugs that are enzymes inducers. So they may not even allow your drugs to work. So we need to check whether he's taking other medication aside from the drugs that he's taking. So usually what we do for drug resistance is to add a second drug for the treatment of the hepatitis. So these are the list of drugs that can be added for usually, basically, the drug that is commonly available is tenofovir. If a person has resistant, or if the drug is not working, from undetectable viral load to detectable viral load, it means the drug is not working. We usually add entecavir, and the patient continue with it too, and that has been working effectively. So now I would like us to look at hepatitis C briefly, which is a RNA virus. And we know that if you look at the life cycle of this virus, it's a beautiful virus. You can see, to differentiate it with hepatitis B virus. In hepatitis B virus, we know that it entered the nucleus. While hepatitis C, it does not enter the nucleus. It just comes into the cytoplasm, multiply there. And if you look at it, that is why hepatitis C is a curable disease, because it does not enter into the nucleus. It just move around the cytoplasm. And once the person takes the drug for treatment of hepatitis C, it's achieved, he is able to respond and get cure for this disease. Usually replication occurs outside the nucleus, and it does not get integrated into the host DNA genome, unlike hepatitis HIV and hepatitis B. And the lack of this latent phase, that's why hepatitis C is curable. So hepatitis C also have genotype, and it has genotype 1 to 6. And aside from the genotype 1 to 6, you can have subtype. You can have 1A, 1B, 1C, like that. And despite differences, all genotypes are similar in their transmission pattern, persistence, and also disease development. And different genotypes are associated with different treatment options, different treatment duration, and different treatment outcome. So for us here in Nigeria, study was done, and the commonest genotype that we have is genotype 1. You can see it's almost like 80 to 90% of patients that are hepatitis C. Most of the genotype, the commonest genotype that we have here is genotype 1. So I've talked about the prevalence earlier on, that is 1.1%, about 2.2 million people are having this virus, are infected with this virus. Male to female ratio is about 52 to 48%, because if you look at the age of infection, usually 40 years and above. Healthcare workers are at greatest risk of this infection. If we look at the natural history of this virus, I've told you about the mode of transmission, which is blood and blood products. And risk factor for disease progression is age, alcohol, co-infection with other viruses like HIV, hepatitis C virus, hepatitis B virus, obesity, diabetes, mellitus. They are all risk factors for progression. Generally, hepatitis C is asymptomatic. In acute phase, hardly will you see them, they are symptomatic. Usually they are asymptomatic. A majority of acute infection becomes chronic infection. About 85% of persons that are infected with hepatitis C virus, they will have chronic hepatitis C. Only 15% are able to clear the virus. But the good thing about hepatitis C, it gives you a long duration of cirrhosis before hepatocellular carcinoma, unlike hepatitis B, that does not, it can change just from chronic hepatitis B to hepatocellular carcinoma. So in the natural history of hepatitis C infection, I'll say exposure in acute phase, 50% may resolve the infection, while 85% may have chronic hepatitis C. And over time, if you look at the timetable, up to 20 to 30 years before the person will come with end-stage liver disease. However, I said earlier on, progression is accelerated by HIV, co-infection with any of the viruses, alcohol, obesity, and so on. So who to screen for hepatitis C? We have Nigeria recommendation for screening of hepatitis C. Person with history of blood transfusion, they should be screened for hepatitis C virus infection. Person who inject drug, that's PWIT. Person with history of hemodialysis, that's those that have chronic renal failure and they are on hemodialysis because they play with blood a lot. They transfuse them, pass through the machine and so on. So they will need to be screened for hepatitis C. Infants born to hepatitis C positive mothers, they should also be screened. Contact of hepatitis C infected person, healthcare workers, especially those with non-history of needle stick or sharp injury. Also, those that have abnormal liver enzymes, they should also be screened for hepatitis C. Persons that are living with HIV, they should be screened for hepatitis C. Also, those that have risk factors like tattoo, scarification, local surgical procedure, they should also be screened for hepatitis C. Also, key population, that's men who have sex with men, female sex workers, history of incarceration. They are all risk factors for hepatitis. So those persons should also be screened. So now, how do we diagnose hepatitis C infection? We have 2 steps. First, screening is the first step. Once, if someone is screened and is positive for hepatitis C viral infection, then the next step is, it means the person has been exposed. But we want to know whether the person has active infection or is an inactive disease. So the next step to do is to do the viral load for the hepatitis C. Once, if the viral load is positive for hepatitis C, it means the person has active infection and he needs to be treated. So unlike hepatitis B, that will say, okay, if the viral load is detectable, then we'll need to do liver function test to look at the ALT before we know whether the person will be treated or not. But for as long as the person does not have family history of cancer of the liver. But for hepatitis C, once you have a detectable viral load, it's an indication for treatment. It means the disease is active and you need to be treated. And also the hepatitis C co-antigen can be done, like in area that people cannot afford the hepatitis C viral load because it's more expensive than the co-antigen, even though it's not readily available in Nigeria. But when it becomes available, it will be far, far cheaper than doing the viral load, in which viral load also is a sign of infectivity. So the person will need to be treated. So this one is just a diagram to show that if you do the test, once if the person is positive, the viral load is detectable. So what the patient needs, he needs to be evaluated further and see, so that we can prioritize the treatment, whether he will need a treatment for 3 months or we can extend the treatment for more than 3 months. So for hepatitis C, what are the pre-treatment assessment? The pre-treatment for assessment for hepatitis C and hepatitis B is the same, because we need to do the liver function test to complete the workup for the treatment. And also we need to do full blood counts. In the full blood count, we want to look at the platelet counts. The platelet count will help us to calculate the APRI score, just because the APRI score is the alkaline aspartate transaminase ratio index, platelet ratio index. So we want to know whether the person may need treatment for a short duration or for a long duration. And it will tell us whether the patient has cirrhosis or not for hepatitis C. If the patient has cirrhosis, it means the treatment will be prolonged. For hepatitis B, it just gives us an idea whether the patient has cirrhosis or not. Also, we will do the renal function test for hepatitis B, because the patient is on tenofovir. Tenofovir has some effect on the kidney. We can switch the patient to entecavir. While for treatment of hepatitis C, because sofosbuvir, we may need to reduce the dose for those that will, if they have renal impairment. Also, we need to do the genotype for all the viruses. Also, other tests that we need to do, aside from the liver function test, the hematological test. We also want to look at the part of the liver function to the albumin and the bilirubin. And also imaging can also be done. Ultrasound, CT scan, MRI. We want to look at the architecture of the liver. We want to see if there are masses in the liver or other causes of liver disease outside hepatitis. And also MRI, you want to check if the patient has cancer of the liver, you want to check whether there is spray of the disease. Also want to look at co-infection, HIV, hepatitis B surface antigen. Also for hepatitis D, if the person is hepatitis B positive, we also want to do this test. So what's the goal of treatment of hepatitis C virus? The goal of treatment is to achieve a sustained virological response, which is defined as cure. What we mean by sustained virological response is that, one, a person that has hepatitis C and has detectable viral load, and he received treatment for 3 months or 6 months, depending whether he has cirrhosis or not. Then after the treatment, 3 months after the treatment, we do another repeat viral load. If the viral load is undetectable, we say that this person has achieved sustained virological response, and the person has been cured of his hepatitis C viral infection. And also another goal for treatment is to prevent progression to cirrhosis, liver failure, and hepatocellular carcinoma, that's cancer of the liver. Also to prevent transmission of hepatitis C to other people. Because once the person is treated, his viral load he's able to clear the virus. It means he cannot transmit the disease to another person. So that is one of the goals for treatment. And also another goal for treatment is to improve quality of life. That's the quality of patient life. However, one thing we have to know, if a person is treated for hepatitis C, it cannot prevent him from reinfected with hepatitis C virus. So that's why counseling is very important, so that he will avoid the risk factor that will predispose him to reinfection. Once, if a person that has hepatitis C is treated and he achieves sustained virological response, it means he has reduced, in fact, most of them, they have normal life, their mortality has been reduced, morbidity has been reduced, and they live a normal life like any other person. Because studies have shown that those that were able to achieve virological cure, they die from other disease like any other person. But for those that were not able to achieve virological cure, their mortality is higher than those that were able to achieve virological cure. So what are the drugs that we use in treatment of hepatitis C? Basically, because of the pan-genotypic drug, most of the time we don't talk too much about the doing genotype. We only come back to do genotype when the person did not respond to the pan-genotypic drug, and we do the genotype so that we can give a specific treatment. So these are the drugs that we use in treating patients with hepatitis C. For those that are with compensated cirrhosis, we use Adasoft, Valpastavel as the first-line drug for both compensated and decompensated. While for those that have cirrhosis, we can extend the treatment to 24 weeks. So what about those that did not respond to treatment? We can use the triple therapy, Sofosbuvir, Valpastavel, and Previr. This drug can be given to the patient. It can be used as first-line drug, and it can be used as second-line drug for treatment of hepatitis C virus. For us here, even though there are people that can afford this, it's an expensive treatment for hepatitis C. That's a triple therapy for those that they can afford. But for resource-poor country like ours, basically what we do is to extend the treatment for a longer duration. We still repeat the drug, and we ensure that the patient compliant, adhere to the drugs, and we extend the treatment for 16 to 24 weeks. Okay, I've talked about this. Okay. For special population, those are HIV positive and hepatitis C, usually we look at the drugs the patient is taking, because some of the drugs are enzymes inducers, while some are enzyme inhibitors. If a patient is taking like efavirenz is an enzyme inducer, so we increase the dose of the daclazivir if the patient is getting daclazivir combination. Well, if he's taking drugs like atazanavir, we decrease the dose because it's an enzyme inhibitor. So we have to decrease the drug. If he's getting like antibacterial, like clarithromycin, azithromycin, or antifungal, we reduce the dose because these are enzymes inhibitors. For hepatitis B and HIV and hepatitis C co-infection, if we're treating hepatitis B, if the hepatitis C is undetectable, it means the patient does not need treatment for hepatitis C, so the viral load is undetectable. But if someone that is hepatitis B positive and is receiving, he has undetectable hepatitis B virus, he's receiving treatment for hepatitis C, you have to, in fact, some say that we have to start them on treatment for hepatitis B first, because drug for hepatitis C is an immune modulator, because the person may reactivate. A week or two into the drug, then you now commence the treatment for hepatitis C. Then after the treatment, you can discontinue if the viral load is undetectable. Then for TB with hepatitis C virus infection, usually we treat the tuberculosis first, hepatitis C. So Mr. Danjuma has talked about the global health strategy, global effort to eliminate hepatitis virus by 2030. In May 2016, adopted the global call for elimination of viral hepatitis as a public health threat by 2030. That is 90% reduction in incidence. That's 95% for hepatitis B and 80% for hepatitis C, and 65% reduction in mortality. Elimination of viral hepatitis as a public health threat requires 90% of those infected to be diagnosed, and those 80% of those diagnosed to be treated. At the 2021 World Health Assembly, World Health Organization releases an interim guidance for country validation of viral hepatitis elimination with focus on hepatitis B and C. While in May 2022, the World Health Assembly noted a new set of integration global strategy for HIV, hepatitis, and also sexually transmitted disease, and that's triple elimination. Based on this previous and the new strategy, a broad range of member states developed comprehensive national hepatitis program and elimination strategy for the global health sector strategy. So for us here in Nigeria, we are not left behind. Also in 2013, Nigeria government established a technical working group for the viral hepatitis. That's through NASCAP to produce a viral hepatitis policy, in which it was done in 2013. In July 2015, Nigeria government launched the national policy for the control of viral hepatitis. And also in 2016, Nigerian government, in collaboration with professional bodies such as SOGIN, other stakeholders, produced a national guideline and national strategic plan for viral hepatitis 2016 to 2020 for the prevention, treatment, and care of viral hepatitis in Nigeria. The national strategic framework also of viral hepatitis was launched in 2022, which covered from 2022 to 2030. So this is the document that was produced by Nigerian government, Federal Ministry of Health, for the control of viral hepatitis. This is the national strategic plan. The documents are readily available. And this is the national strategic framework that was also developed. So Nigeria principle of combating hepatitis C infection management. We have the universal health coverage, government ownership at both federal, state, and local government level. Also partnership and intersectorial collaboration with professional groups, agency, farmer, and community leaders. Also a public health approach. I will talk a little about this public health approach. Like us here in Nasarawa State, because I practice in Nasarawa State, we have adopted a public health approach in which persons that have hepatitis C in particular, they don't need to go far before they will get treatment, because the Nasarawa State has trained almost everybody in the secondary health sector. Once if you're a doctor in secondary health facility, you are trained how to treat hepatitis C. You don't need to refer the patient to the gastroenterologist. You only refer those that have complications and those that fail treatment. Those are the ones that they are being referred. So we adopted a public health approach, and the government of Nasarawa State has also launched the hepatitis C elimination project, which was launched in 2020 to 2025. The government of Nasarawa State has procured a drug at a subsidized rate. Person gets solved their class survey for 15,000, less than 15,000 a month. So with less than 50,000, you can treat yourself for 3 months. And this strategy has been put in place to eliminate hepatitis C viral infection in Nasarawa State. So in conclusion, most of the hepatitis patients in Nigeria are not aware of their disease status. And we need to address that to prevent disease progression and late presentation of the disease or its complication like cirrhosis, cancer, or death. However, the laudable decision of Nigerian government of establishing a viral hepatitis document, answering the clarion call by World Health Organization to globally eradicate viral hepatitis by 2030 is commendable, but not without its challenges. To meet global target of eliminating viral hepatitis by 2030, government must put structure in place to implement the outline national viral hepatitis strategy plan through massive education, training of health workers, expansion of health facilities, and also subsidizing the cost of management of viral hepatitis through expanded health insurance scheme and the involvement of critical stakeholders such as pharma, so that we'll be able to combat this disease by 2030. Thank you for your attention. Thank you.
Thank you, Dr. Ruth, and I hope all the participants have immensely benefited from your presentation. We have a question, but I want to say this, that the drug reduction in Nasarawa, we helped to facilitate that discount with Beatrice. We were the ones that brought the company to the table with Chai to even have those negotiations. And in fact, we got that before even the public announcement in Geneva for the $60 for the whole treatment. So we are part of the journey of supporting. When I say we, I'm referring to the World Hepatitis Alliance. We facilitated a discussion with Chai, and yeah, we're hoping that this can be scaled to other parts of Nigeria. So we have a question here for you. Now, what is the role of, though we are really on the dot of time, but just that one question, what is the role of mathematical modeling in hepatitis analysis globally in Africa and in Nigeria by Dr. Sani Suleiman? Would you want to answer that briefly before we finalize?
No, actually, I don't know.
Okay. So Dr. Sani Suleiman, mathematical modeling helps to give maybe helps to present data and helps to project probably maybe incidence prevalence of either a particular disease. For hepatitis in particular, it's really challenging to do mathematical modeling in a country like Nigeria without even good data, right? So we've had challenges even with working with WHO recently to do to generate models that will really help. So, but mathematical modeling really helps to provide policymakers on guidance on how to make decisions. So it gives you a projection using baseline data of interventions is used to help maybe to make projections about either the occurrence of epidemic or cost or investment. So it depends on what it is actually that the modeling is to look at, but it works. It has to use data as a baseline to be able to make those projections. So Jess, I don't know if there are maybe comments or questions, then we will probably have to round up.
No, I don't think there's any more questions. I think this has been incredibly informative and, you know, great to hear sort of the outlay, the testing and treatment. I think what will be particularly interesting maybe as a follow-up for us is to look at, you know, what's available within the different states, because I'm sure that that's a burning question that a lot of people have.
Yeah. So let me also add that I want to sincerely appreciate everyone and to let us know that the hepatitis B treatment guideline is being simplified. Hopefully, the new guideline will be available that really brings a more simplified approach to testing and treatment. So the guideline hopefully is looking at maybe hopefully around October, the WHO will release the guidelines, and presumably the guideline is maybe going to scale, maybe improve more access to testing. I don't want to preempt it, but it's really a game changer in hepatitis B care. And that is something that is really going to do a lot across Africa, especially LMICs. And Dr. Ruth is a hepatologist. Most of the patients Dr. Ruth see are people that have ACC. So we want to test more people. We want to ensure that more people get tested and we prevent the ACC. Dr. Ruth, it's very challenging that we see so many alarming cases of ACC attributable to hepatitis B, especially within Nigeria and within Africa. So the new guideline will be out very soon. This is a good news to all of us, especially in Africa, that as soon as it's out, it's going to really be a big game changer in improving testing, simplified diagnosis, and even eligibility for treatment. In fact, the guideline handles eligibility for treatment. So it's going to be out very, very, very soon. Jess, over to you and over from me. Thank you.
Great, thank you. I know we're at time. I just want to acknowledge there's a really great question there's some questions in the Q&A, and one of them is, you know, hepatitis is 100 times more fatal than HIV, and why is there no modalities in place for free treatment? And I think this is a really good point and something that we as the whole community are advocating for. And I know Danjuma is definitely engaged with that in Nigeria and globally as WHO president. So I know that we're on time. So Danjuma, do you want to close us off?
Yeah, thank you, Jess. And before I close, I want to just throw this to Dr. Ruth. As a hepatologist, what can you say? Just briefly, Jess, don't pardon me to just say this.
No, we can run over.
What could we do differently to avert the rising cases of ACC, especially in Africa? Attributable to hepatitis B.
What can we do?
ACC. What can we do to avert the rising case of ACC attributable to hepatitis B, especially in Africa?
Well, what we can do is early diagnosis and treatment. Because once, if a patient is diagnosed early and is treated, it slows down the progression of the disease. And for those that are cirrhosis, I've treated a patient with cirrhosis that reverted back to normal liver. So early treatment is the key. So screening and early treatment. And I think time will come that we just do treat and tests for hepatitis. Time is coming.
Yes, we're aiming towards that. And thank you so much, all the participants. For us, it's very important as patient advocates, as civil societies, to understand the basics about testing. As an advocate, if you don't know the science of what you are advocating for, you don't have the capacity to be in the space to even provide proper counseling. And that is why this training is very important to all of us patient advocates, to understand the basics about the disease we're advocating for, and even to know the best practices in the testing. And that's why we had Dr. Ruth. She has been so supportive of the work we do, and she has been very wonderful in helping. And thank you, all of you, for being on this call. We hope that the lessons you've learned, what you have gained today, please, you translate into action. We need more testing. Don't forget, July 28th is World Hepatitis Day. So please carry out activities to test people in a quality way, link people to care so that we avert HCC cases in Africa. At the World Hepatitis Alliance, we're happy to know what you are doing. Share with us. Let us know the activities you're carrying out. I'll be very happy to showcase what you're doing. Jess is here as a director at the Alliance. I know she'll be very happy to showcase what is going on in Africa. So from the World Hepatitis Alliance, we want to say thank you so much for joining. It has been immensely grateful to have you all on the call. Dr. Ruth, we appreciate you for joining. Jess, you've been so supportive of this. Thank you so much for pulling this through over the past few years. I told you we're going to give you Nigerian passport very soon so that you get the Nigerian citizenship. You've done a lot to support hepatitis advocacy within this region. So thank you so much, everyone. And we hope that we see you very soon with more webinars on World Hepatitis Day and more learnings to improve our skills as patient groups and as advocates to improve care to our communities. Thank you, and bye-bye from us.
Thank you. Bye-bye, everyone.
Bye.
Bye.